As part of the required coursework for the fulfillment of the Doctor of Nursing Practice degree in nurse anesthesia at Franciscan Missionaries of Our Lady University, the students have synthesized and critically appraised current evidence regarding the topic of interest. For the scholarly project, the students constructed a systematic review of literature. To demonstrate the attainment of scholarship skills, the doctoral students have created a PowerPoint presentation to disseminate our findings from the systematic review. My name is Caitlin Prejean, and I am a nurse anesthesia student at Franciscan Missionaries of Our Lady University. For our doctoral project, my partner, David Mooney, and I systematically reviewed current literature regarding the use of apneic oxygenation to prevent rapid oxygen desaturation in obese patients. We have constructed a PowerPoint presentation to provide you with a brief summation of our findings from our systematic review. Obesity, defined as a body mass index greater than or equal to 30 kilograms per meter squared, has historically been associated with detrimental effects on pulmonary function. Increased accumulation of adipose tissue around the abdomen, rib cage, and diaphragm contributes to increased intra-abdominal pressure and decreased chest wall compliance. These alterations in normal respiratory mechanics directly affect lung volumes and spirometry values. Due to respiratory variations and an increased oxygen requirement, obese patients are prone to accelerated oxygen desaturation during the induction of general anesthesia and poses a significant challenge for the anesthesia provider. To help anesthesia providers overcome these challenges, apneic oxygenation has been used in a variety of settings to improve oxygenation during anesthesia induction and securement of the airway. Well, what is apneic oxygenation? Apneic oxygenation is a method that involves the placement of a delivery device and the institution of oxygen at a set rate during anesthesia induction and the subsequent apneic period. This allows for passive flow of oxygen from the alveoli into the blood. When used in conjunction with adequate pre-oxygenation techniques, apneic oxygenation presents the anesthesia provider with a potential method for prolonging the safe apneic period. Prior to conducting our research, the students chose a theoretical framework to serve as the foundation for our systematic review. The theoretical framework in which we chose, the theory of unpleasant symptoms, is a middle-range theory based on the application of existing clinical knowledge to improve the management of patient symptoms. There are three major components to this theory: the symptoms that the individual is experiencing, influencing factors that produce or affect the symptom experience, and the performance outcomes. Rapid oxygen desaturation during endotracheal intubation in obese patients is a common and dangerous phenomenon. Therefore, the objective of our systematic review is to determine if apneic oxygenation can prevent rapid oxygen desaturation during endotracheal intubation in obese surgical patients. To construct our systematic review, the students formulated the research question utilizing the PICO format. The P in PICO stands for participants. The types of participants included in our review included obese and morbidly obese men and women requiring general anesthesia and placement of an advanced airway for elective surgery. As additional anesthetic considerations must be taken into account in the obese pediatric population, studies were excluded if the participants were less than 18 years old. Moreover, studies were excluded if the participant's body mass index was less than 30 kilograms per meter squared, as a body mass index less than this number is not considered obese. The I in PICO stands for interventions. The types of interventions included in our review included all studies that investigated the use of both high-flow and low-flow oxygen devices to evaluate the efficacy of apneic oxygenation in obese patients undergoing general anesthesia. Of the studies reviewed, apneic oxygenation was employed via nasopharyngeal airway, buccal ray tube, transnasal humidified oxygen delivery system, and nasal prongs. No interventions were excluded from the review. The C in PICO stands for comparisons. Comparisons included in the studies were the institution of standard pre-oxygenation, apneic oxygenation with air, and no intervention. However, since pre-oxygenation is a standard of care and should be instituted in all patients undergoing the induction of general anesthesia, We did not include a comparison in our research question. The O in PICO stands for outcomes. The outcome measures evaluated in this systematic review included a prolonged apneic period and/or the prevention of oxygen desaturation. Among the studies reviewed, the apneic period is defined as the time required for the oxygen saturation to reach less than 95%, or a maximum allowed apneic time, which was designated by the researchers, ranging from 4 to 8 minutes. As a secondary outcome measure, all of the studies recorded the end tidal carbon dioxide at the cessation of apnea. For the purpose of our review, we excluded the end tidal carbon dioxide measurement as this was not pertinent to answering our research question. Types of studies included in our systematic review were all randomized control trials published in English investigating the use of apneic oxygenation in obese patients undergoing general anesthesia. Additionally, we included one descriptive study by Patel et al. 2015, while one literature review and one systematic review were excluded due to decreased credibility and an unsatisfactory level of evidence. An exhaustive search of relevant literature was completed to identify scholarly peer-reviewed journals published in English from September of 2009 to September of 2019. The students systematically searched the following databases: CINAHL Complete, Medline Complete, Ovid Lippincott Journals, Nursing and Allied Health Database, and Health Source. Additionally, utilization of Google Scholar and manual reference checks of current literature were performed to identify additional pertinent literature. The students independently searched the databases using the following search terms: obese, apneic oxygenation, high-flow nasal cannula, extend safe apneic time, apneic period, delay onset of desaturation, and endotracheal intubation. Limiters applied to our search included scholarly peer-reviewed journals published in English between 2009 and 2019.
Literature section. The 48 articles were initially screened by title and abstract. Articles were included if the title and/or abstract discussed the use of apneic oxygenation in the obese population. A total of 39 articles were excluded based on the information provided in only the title and abstract. The remaining 9 full-text articles were screened for eligibility, and 3 additional articles were excluded. The first study was eliminated due to its focus on non-obese patients. The second study was excluded due to low-quality evidence. Lastly, a systematic review was excluded as it provided duplicate information from Ramachandran, Kanowski, Shanks, and Turner, a study previously selected for inclusion that better suited the review. Therefore, 6 full-text articles were included in the systematic review of literature. The students utilized a Prisma flow diagram to complete the selection process. The final systematic review included 6 research studies that implemented the use of apneic oxygenation in obese patient populations. Of the 6 studies chosen for appraisal, the students assessed 5 randomized controlled trials and 1 descriptive study. The studies were conducted in Lebanon, the United States, the United Kingdom, Canada, and Australia from 2009 to 2019. Across all 6 studies, there were 304 participants, including both male and female obese patients. The studies included multiple participants that ranged from 25 to 135 in number. Results: utilizing a wide variety of high and low flow oxygen delivery devices, all 6 studies investigated the effectiveness of implementing apneic oxygenation and its ability to prolong the apneic period in obese patients during endotracheal intubation. Following the onset of apnea, the studies defined the primary outcome, safe apnea time, as the amount of time required for peripheral oxygen saturation to reach 95%, or maximum apnea times ranging from 4 to 8 minutes. The studies instituted similar methods of data collection by recording the peripheral capillary oxygen saturation at baseline and specified times throughout the induction period. Therefore, once the oxygen saturation fell below 95% or participants surpassed the maximum allowed apneic time, apnea was terminated and the times were recorded. Overall, 6 studies demonstrated increased apneic times when instituting apneic oxygenation in the obese patient population. Results: The systematic review was organized into two themes, low-flow oxygen delivery and high-flow oxygen delivery. The students defined low-flow oxygen delivery as when the researchers instituted the use of oxygen at 15 liters a minute or less, and high-flow oxygen delivery was when the researchers instituted the use of oxygen at greater than 15 liters a minute. The studies that instituted low-flow oxygen delivery are as follows. Brock et al. 2007, Hurd, Toner, Evans, Palacios, and Lar, 2017, Moon et al. 2019, Ramachandran et al. 2019. The studies that instituted high-flow oxygen delivery are as follows. Patel and Norrie, 2015, and Wong et al. 2019. In conclusion, all 6 studies showed positive results when using apneic oxygenation in the obese patient population. Discussion. Even though all 4 studies that used low-flow oxygen delivery generated significant results, Brock et al. 2007 and Moon et al. 2019 were assigned with a high level of certainty using the U.S. Preventive Services Task Force levels of certainty. However, Ramachandran et al. 2009 and Hurd et al. 2017 highlighted substantial limitations to their research. Therefore, due to the limitations, Ramachandran et al. 2009 and Hurd et al. 2017 were assigned with a moderate level of certainty. Consequently, utilizing the U.S. Preventive Services Task Force ratings level of certainty regarding net benefit to grade the summation of evidence, the overall evidence regarding low-flow oxygen delivery was assigned a moderate level of certainty. While different flow rates and devices utilized amongst the 2 studies implementing high-flow oxygen delivery, both studies produced results supporting the use of high-flow oxygenation in obese surgical patients due to its ability to prevent rapid desaturation during the apneic period. Although Wong et al. Would be assigned with a high level of certainty if assessed in isolation, the study by Patel and Norrie, 2015, presents several limitations to its design. Therefore, utilizing the U.S. Preventive Services Task Force rating level of certainty regarding net benefits, the students collectively assign the studies regarding high-flow oxygen delivery with a moderate level of certainty. Author's conclusions. There are several strengths of the studies included in this systematic review. First, Brock et al. And Moon et al. 2019 blinded the participants to their assigned groups, decreasing the likelihood of bias. Next, Moon et al. 2019 and Ramachandran et al. 2009 compared an intervention group to a control group, therefore strengthening the results of the study. Additionally, 5 of the 6 studies included in the systematic review were randomized controlled trials. As true randomized controlled trials provided high-quality evidence, this further strengthens the results of this systematic review. Furthermore, the studies were conducted in several different countries, including Lebanon, Australia, the United States, the United Kingdom, and Canada, which speaks to the diversity of apneic oxygenation as it is being successfully utilized worldwide. Author's conclusions continued. The limitations of the studies include the use of several different techniques, leading to slight variations in the interventions. The interventions included the administration of high-flow or low-flow oxygen and the use of additional resources such as a buccal ray tube, nasal cannula, nasopharyngeal catheter, and high-flow transnasal oxygen delivery system. The dissimilarities among the interventions led to some difficulty interpreting the overall results and answering the student's PICO question. In reviewing Patel and Norrie, 2015, the researchers did not incorporate blinding into the study, which of course leaves a great deal of room for bias by the interpreter, the administrator, and/or the patient. Author's conclusions continued. The purpose of this systematic review is to determine if apneic oxygenation can prevent rapid oxygen desaturation during endotracheal intubation in obese patients. Based on the evidence reviewed, apneic oxygenation serves as an effective method to prolong the safe apneic period in the obese population. Therefore, apneic oxygenation can function as an essential tool for providing safe intubating conditions in obese patients. Additionally, if the anesthesia provider encounters a difficult airway, apneic oxygenation offers additional time for intubation. Furthermore, when reviewing the research, multiple variations exist concerning apneic oxygenation techniques. Although studies utilize various oxygen delivery devices and flow rates, apneic oxygenation has shown to be effective in preventing rapid oxygen desaturation in obese patients. Another significant benefit is that the tools for implementing apneic oxygenation are easily accessible to anesthesia providers. Therefore, apneic oxygenation serves as a simple and effective adjunct for intubation in obese patients. Author's conclusions continued. Due to the utilization of various devices, high and low flow rates, the use of both oxygen and air, the students are unable to conclude the best methods for preventing rapid oxygen desaturation during direct laryngoscopy. Therefore, future studies should include an intervention group, a group receiving oxygen via oxygen delivery device during the apneic period, a comparison group, a group receiving air via oxygen delivery device during the apneic period, and a control group, a group receiving no intervention during the apneic period. Moreover, studies comparing high and low flow oxygen delivery and additional research comparing the efficacy of oxygen delivery devices would provide an enhanced understanding of the interventions that significantly prolong the apneic period.